All right, so we have Shauna set up for Torticollis. We have her draped. We have a beautiful line of draping here. That still matters. We want to make sure that all the details matter. So with Torticollis, it's really, really important to keep your patient's head as steady as it possibly can be. There's not a lot of moving it around because we're talking about an acute spasm. So we'll talk about this as an acute spasm, and that it's this side that we'll be working on primarily. There's not going to be a lot that I want to do here in terms of like moving her head around. So those of you that are a little bit more on the aggressive side for effleurage, that you can't do. Like you can't be doing this to your patient and having their neck move up and down. That will cause a lot of pain for your patient. So everything is going to be kept very, very steady and very, very stable. So the first thing that I'm going to start with is literally just going to be some origin insertion work. And a lot of that is going to be directed towards the SCM. You can obviously do it on the opposite side, but you can't see that, so I'm not going to show you. With the SCM, when I do origin insertion work, I really want you to focus on where the origin and insertion actually is. So if I take her SCM and pick it up, we can see how big and how thick this is. And coming all the way up to its insertion point here, we've got it around that mastoid process, but it's also about 1/3 of the occiput. And a lot of people end up remembering to say that when they ask for origin insertion of SCM, but most people don't actually treat it. So if we find that posterior border of the SCM, we can see that lifted up right there. So we can see how far back that goes onto her actual occiput, whereas her mastoid process is right here where my finger is. So occiput, mastoid process. We want to make sure that when we're doing origin insertion work that we're going all the way along that origin there. And then on the other side, I want to make sure that we're really clear of how far along the clavicle it goes. So if I'm pushing up there we go. We've got that border of the SCM, and then on the other side, it's right about there. So we've got a couple inches apart of where I'm going to be doing my origin and my insertion work here. So you can do whatever type of thing you want. Please note it's a really subtle thing, but this arm is on the other side of her head. It's basically doing this, but on the other side. It's so that when I push her head, it doesn't go anywhere, so that it's already blocked. Whereas if I don't have my hand here and I'm working on one side, her head is likely to move with pressure. So I'm gonna have one hand just on the other side, just supporting her head, so that when I do apply pressure to this side, her neck isn't gonna move, and then therefore it won't irritate the acute spasm. So you can just apply pressure to those origin insertion points. You can apply your little pluses or your X's, whatever works for you. But you're gonna be spending quite a bit of time just trying to release that spasm in a really, really gentle, gentle way. Okay, when we do it, we make sure we come all the way back. Okay, all the way to the back of the occiput. Okay, and then I'm going to do the same thing on her insertion side. So make sure that you're getting that sternal portion of the SCM. And then make sure that you get all the way into that clavicular portion of the SCM as well. So we've got our full origin of that there. Again, pluses, X's, pressure, whatever works for you. So I'm not going to be treating the SCM directly because, again, it's in spasm. So we can do the same thing, but with, like say some of the compensating muscles, like let's say scalenes, I can do some origin insertion release. Get into the insertion of scalene there. You'll be able to feel it because it'll drop behind the clavicle and get deep. You could treat the upper traps as long as the head's not moving around. You can do a little bit of point pressure there, picking up that upper trap. It's all really, really gentle, and it's all really, really slow. Like even for this, I'm kind of rushing through it just so that you're not watching a boring video that's 12 minutes long of me not doing very much. But it's gonna take a really long time, and you're gonna go really, really slow. With spasm, a lot of people, what they'll like to do is the harder they go, the deeper they go, the faster it'll release, and that's just not true. Your body is on really, really high alert. Your body is like really sensitive to anything that it's going to interpret as trauma. But the sensitivity, the neurosensitivity of the body right now is just absolutely maxed out. So when something like a neck is in spasm, anything that I do has to be perceived as helping. If I instigate pain, we're going to end up with this like firing of neurological systems, and the body is just going to go, oh my God, no, not happening. So we want to make sure that everything that we do is perceived as help, as perceived as trying to calm the nervous system, which is why all of your hand motions are going to be really, really slow. All of your techniques are going to be really, really slow. Because if you do anything too fast, if you set off this spasm by, let's say, jerking the head a little bit, that muscle is just going to go really quickly and respond in a negative way. So everything that we do needs to be really, really gentle. So I'm going to stabilize the head. I'm going to work on her posterior cervicals and just do a little bit of kneading back there. But again, the other hand, this hand is holding onto the neck and essentially doing this so that when I treat, her head is not going anywhere. So we've got one hand stabilizing. We've got the other hand doing tiny little circles. If you want to get lotion involved, you absolutely can. Again, as long as you're being super gentle. If you want to do a suboccipital release, you absolutely can. Hands are going to come up really, really gently and really, really slowly under the head. And then your fingers are going to end up in that suboccipital space. Really, really gentle, really, really slow. Making sure that I'm not setting off anything in that neck region. Okay, you might even want to apply just a tiny little bit of traction, but again, the traction is going to be really gentle. So I'm just going to get one hand around here, other hand around there, and then just a real gentle pull. I'm not trying to rip her head off. I'm just trying to create a little bit of space. Her body might react well to it. Her body might tighten up. If her body tightens up, I'm going to stop. But if her body's like, oh yeah, that feels good, then we're going to keep doing it. Okay, the last thing that we can do here is I'm gonna get her other SCM to fire. Okay, this is not resisted range of motion. This is literally, I'm trying to trigger reciprocal inhibition. So I do get her to resist, but it's to fire off this SCM in hopes that this one will turn off and shut down, okay? So if I push here, that would cause this SCM to contract with lateral flexion. So I'm going to do that on the opposite side. 1, 2, 3, 4, 5. Good. And then I'm going to get her to rotate. So when this SCM shortens, that she would rotate the opposite way. You would side flex this way. There we go. And rotate the opposite way. So I'm going to get her to rotate this way. Okay? Am I doing this right? Yeah. 1, 2, 3, 4, 5. Okay? So this SCM is going to fire for both of those movements, and that's what we want. So it's really, really gentle, gentle contractions, and it's just enough so that this can fire off without causing this SCM to fire. We're just trying to get reciprocal inhibition going, okay? So those would be all of my techniques that I'm using. Most important thing is that we're doing it super, super gently. Everything is super slow. This neck is not being moved around a whole lot, okay?